Thank you. Thank you for joining us.
Thanks for having me.
So let's start with BioMosaic. Can you tell us a little bit about it?
Sure. Is the mic on? Or what? Everybody can hear okay? Great. BioMosaic is a tool that I've developed out of a need that we faced in CDC for integrating lots of data, the sort of big data when it comes to public health. And so at its start, it was three pillars: bringing together demographic data from the census, bringing together all the migration data, movement, air traffic, which is a major driver in emerging infections, and then bringing together health burden data. We started this as a pilot project about 4 years ago with two collaborators in academia, Cameron Kahn from the University of Toronto and John Brownstein from Boston Children's at Harvard. And it has now moved into sort of a full-on implementation phase. Not quite on?
Not quite on. Let me see your backup.
Okay. I was worried about that. I switched the button.
That's what it was.
On now? All right. And it's now moving into sort of beyond the pilot into implementation, and it has integrated a lot more data layers. So there are a number of big data sets that we access and aggregate. The common feature is that all of them are geocoded. So we bring in weather data, climate data, we bring in global distribution of poultry, we bring in distribution of swine populations, vector disease incidents from WHO and other data sets, and pulling all these things together and then putting them in a way that they could be easily visualized or queried. The front end is a mobile application as well as a very detailed analytic platform on the web that sits behind the CDC firewall. And increasingly, other countries and governments are making queries to BioMosaic in order to do predictive analytics and assessments. It's come in tremendously handy in most of the epidemics that have been introduced as part of our background. We use them in forecasting, we use them in testing, we use them in targeting interventions and surveillance, and it has been an extremely helpful tool very recently in the Ebola outbreak.
So give me an example of something that you were able to do vis-a-vis fighting Ebola because of BioMosaic that you wouldn't be able to do otherwise.
Sure. So a perfect example is we have the sort of near real-time availability of the global air transportation network, and we're able to identify and, in a sense, target the risk populations, both the diaspora populations from Liberia, Sierra Leone, and Guinea, where they're distributed down to the county and below level. So we have a mosaic map of the U.S. and, in some cases, with other countries' data beyond that.
And that's from census data?
Yeah, the American Community Survey, many people don't know, but since 2000, the American Community Survey has replaced the decennial census in doing an annual survey of big data, social determinants, country of origin, country of birth, many, many aspects. So we roll that in. It comes in annually, and every 3 years it's rolling average in 5 years. And so we have that picture all the way down to census tract and block. But we also have the International Aviation Transport Association data for all the flights that happen around the globe, origin and destination, mid-transit points. We have all the data from Department of Homeland Security regarding the types of passports people are carrying when they enter the over 300 ports in the U.S. So we have essentially this mosaic map of the diaspora population, both on the move and statically in terms of the resident population. Many people don't appreciate how much the global migrant not only impacts health, but is also a driving factor in the economy. And taken in aggregate, those who live outside their country of birth for more than 12 months, which is the UN definition, make up somewhere around 235 million people. It would be the fifth largest population if it were its own country. And they're scattered globally around the world. It's not just a poor to rich migration. There are some countries in the Middle East in which 80% of the population is born abroad. Sometimes these populations fall outside the traditional surveillance and health and public health infrastructures of those countries. They're often vulnerable and neglected in many ways. And as a result, the ability for disease to emerge and to move with the movement of the global migrants is really quite profound. So you asked about Ebola. What we do is we've tracked all the people leaving the three heavily epidemic countries right now, in Sierra Leone, Guinea, and Liberia. And about 100 to 150 arrivals happen a day. We knew that they arrived at 42 airports, but the top 5 made up 94%. And recently we've been able to funnel all the itineraries into those top 5. And then we know where the diaspora population is. They move on to 42, 46 different states. And we use this as a tool to develop a public health program at our airports on entry. So we have a CARE program, which stands for Check and Report Ebola. And we have public health ambassadors at each of these 5 large receiving airports. And we meet every single person, have the opportunity to talk to them, stare them in the eyes. More recently, we're rolling out a program where we give them donated mobile phones. We have a way to connect to them. And then we share that information within hours of every arrival with each of the state and local health departments in the United States. And they can begin to do a 21-day monitoring period in order to keep track on this population that may be of some risk. It's extremely helpful to be able to monitor the mobility, the arrival point, and tailor our educational interventions. We have exit screening also in place at the 3 countries. So we've built up an infrastructure and trained the airport authorities in those 3 countries, and people are screened on the way out. That prevents cases from immediately being exported globally. But the incubating cases that are asymptomatic, that may have been exposed but could get sick over the next 21 days, we need to monitor through this entry screening and post-arrival monitoring program. And BioMosaic is one very useful tool in being able to help with that type of risk assessment. That's just one example.
So, you know, Ebola, which was kind of dominating media headlines maybe a month or ago, even a few weeks ago, has now receded. Does that reflect anything which has actually happened in terms of the threat level in the United States, or the degree to which it may or may not be contained in those 3 countries in West Africa? Or has the media just lost attention because the media is fickle and actually it bears no relation to what's actually happening?
I won't use your words about fickleness, but I will say that epidemics of disease are frequently followed and complicated by epidemics of fear and epidemics of stigma. And in order to combat the epidemic of disease, we need a full-on front. And I think what we saw in the U.S. after the case in Dallas and after the healthcare worker, the very brave healthcare workers that returned and developed illness, is the epidemic of fear in the U.S. And it's a gruesome and merciless disease. The fear is understandable, but part of our job at the CDC and the healthcare community writ large is to put context around those things. Epidemics don't occur in a vacuum. They occur in a context. It's a scary disease. And what we need to do is make sure we get the balance right when we speak in the media and try to put it in context. You asked about how it's going in West Africa, which I think, ultimately to reduce the risk to the American public, the disease needs to be controlled at the source. It needs to be controlled in West Africa, and there's still, the response has scaled up dramatically, but there's still much more to do. The exponential growth in Liberia has been tempered somewhat, but in Sierra Leone it's still growing at a very rapid rate, in particular in the western districts, and Guinea has been sort of fluctuating with highs and lows. So the epidemic is far from under control in West Africa, and we're really going to need to keep our eye on that ball in order to ultimately protect things. I want to jump to one other topic because
Please.
People say, well, why don't we just have a travel ban? Why do you have to go to all this work to do risk assessment? And I want to point out that often the knee-jerk response, which we heard a lot of political calls for early on, especially when cases occurred in the U.S., paradoxically could have the wrong effect. And it's with the amount of global mobility that goes on, it's almost impossible to really choke a place and to fully isolate a whole set of countries. People move, and they're going to move. And what happens is there's a couple of negative consequences of trying to achieve a travel ban. If you choke the epidemic, not only will you restrict movement of the humanitarian response in and out of the region, which is so critical to control it, you also are likely to drive an economic collapse of these 3 countries in West Africa, which could cause a refugee crisis and a mass migration across borders. And suddenly now, in a controlled situation where we have exit screening, entry screening, risk monitoring, we're able to understand the flow, and it's not driven totally underground. When you drive these full-scale travel bans, you just drive all of the human nature of movement underground. People will cross land borders into other countries, find circuitous ways to travel, and we will have lost our ability to assess the risk, to educate, to intervene, and to monitor. So paradoxically, the threat actually increases by those things in which many people would think, sort of in a knee-jerk way, well, let's just shut it off. It just doesn't work that way. Diseases don't respect borders, so.
Let's turn it over to you. We each have a few minutes. I've got many more questions if but I thought of...
We have a question live from Twitter. Brett Johnson asks, how will changes in net neutrality policy affect data sharing and healthcare?
Well, that's an interesting question. Probably not right up my, my lane. I'll speak from a sort of public health point of view that increasingly for public health to take advantage of big data, there needs to be both the sharing and the contribution. Some of the data sets in BioMosaic are proprietary, for example, and some of it are government source data. But all of it is dependent on a pretty healthy flow and a pretty healthy level of engagement. And I'm not sure that in the absence of sort of net neutrality that you're going to get the kind of exchange that we're looking for in order to get this contribution. I know John Brownstein, one of our collaborators, is sort of a big proponent of crowdsourcing for surveillance, participatory epidemiology. And again, if you end up with these tiers of speed and access, your ability to get representativeness in terms of participatory surveillance and epidemiology could be compromised and exaggerate the bias and the gaps that were mentioned in the previous panel discussion. So I'm not really an expert on net neutrality, but I do see that without it, there's some limitations in that regard.
Great. Thank you for the question right up here.
Hi, Joy Payton from the Children's Hospital of Philadelphia. I was wondering if you could speak to some of the ethical aspects, because the type of data you're talking about seems very, very granular. And I know that decennial census data has been used historically for Japanese internment camps, and you've talked about fear-mongering and the epidemic of fear. So I wonder if you could talk about how you safeguard the privacy and the need for human respect for some of the real people that you were talking about in real populations.
That's an excellent question, and you hit on one of the really critical issues that we focus on regularly, especially in CDC with regard to personally identifiable data information, PII. And so there are lots of ways in which this has been dealt with in the public health sphere. There's lots of rules and algorithms. Most of them have to do with how you can anonymize data around cell size. And so firstly, to say that the BioMosaic toolkit is an analytic toolkit secured behind the CDC firewall and is not a public access tool in this case. The public-facing aspects of BioMosaic would then go into these same kind of algorithms to protect PII, which would mean as cell sizes get small enough to cross and triangulate and identify, you blur them by expanding the geographic boundaries so that people can't be found. I think my colleagues that have worked extensively in the HIV arena have worked through a lot of these issues and challenges, but it's absolutely important to maintain. Even simply, my job is basically to look after the global health of the migrating population and prevent importation and spread. And there are great disparities among the vulnerable, and often the vulnerable are in foreign-born ethnic groups and so on. And how to define the burden, and quantitate the disparities, and then intervene and create, progress in closing the gap, means that we have to collect these types of data. But how to protect those individuals from stigma is absolutely critical. And so it goes hand in hand. In the Ebola response, we have a set of people whose only job it is to look for issues of stigma and try to overcome them. And the vaccine for stigma and fear is education. And the best way to address those tools is to bring people into the same space with regard to the level of education. But I think you hit the vulnerability of these same populations, and the need to protect private information is actually quite critical. As someone said in the previous panel, it is remarkable how much privacy individuals are willing to compromise for things that they're unaware of, particularly in the business sphere. And yet, when we ask, for example, we asked about collecting contact information for these people arriving so they can be monitored, and most people actually would like to be contacted if they were on an airplane and they ended up sitting next to somebody with a communicable disease. So we've done a lot of polling and surveys with Harvard and other groups and found that 95 to 99% of people, international travelers, would willingly relinquish private contact information for the opportunity to be reached in the event of a health emergency. And so the areas around this also involve getting the right balance of transparency, assessing needs, and getting involved in quality consent processes and so on.
Great. I think we're out of time. Dr. Cetron, thank you very, very much. Thank you all.
Thank you.
Thank you so much, Peter and Dr. Cetron. I want to thank everybody for being here today. We're so grateful to the support of Blue Cross Blue Shield Association for underwriting this series, and to Independence Blue Cross for making today possible. Your feedback is vital to us. If you would fill out your comment cards before you go, that would be wonderful. And I want to also note that everybody here is invited to visit the Glackens exhibit before you go. So thank you so much for being with us here today, and everybody enjoy your afternoon.